Uveitis. Uveitis means inflammation of the uveal tract, which is formed by the iritis, ciliary body, cyclitis, and choroiditis. Inflammatory eye disease may also originate primarily in the retina, retinitis, or retinal blood vessels, that is retinal vasculitis. Intraocular inflammation is classified as anterior uveitis, posterior uveitis, or panuveitis. Uveitis may also be termed acute or chronic, and granulomatous or non-granulomatous. In most cases, the pathogenesis of uveitis is primarily immunologic, but in immunodeficiency states, infection may be the cause. Clinical findings. In severe anterior uveitis, there may be hypopyon, that is layered collection of white cells. Hypopyon, 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 and fibrin within the anterior chamber. In virtually all forms of anterior uveitis, the pupil is small and with the development of posterior cinchae, that is adhesions between the iris and anterior lens capsule. Cinchae, SynechIae, cinchae. It also becomes irregular. Non-granulomatous anterior uveitis tends to present acutely with unilateral pain, redness, photophobia, and visual loss. Granulomatous anterior uveitis is more indolent, causing blurred vision in the mildly inflamed eye. In posterior uveitis, there are cells in the vitreous. Inflammatory lesions may be present in the retina or choroid. Fresh lesions are yellow with indistinct margins, whereas the older lesions have more definite margins and are commonly pigmented. Retinal vessel sheathing may occur adjacent to such lesions or more diffusely. In severe cases, vitreous opacity precludes visualization of retinal details. Posterior uveitis tends to present with gradual visual loss in a relatively quiet eye. Bilateral involvement is common. Visual loss may be due to vitreous haze or opacities. Inflammatory lesions involving the macula, macular edema, retinal vein occlusion are rarely associated optic neuropathy. Etiology. The systemic disorder associated with acute non-granulomatous anterior uveitis are ankylosing spondylosis, reactive arthritis, psoriasis, ulcerative colitis, and Crohn's disease. Behçet's syndrome produces both anterior uveitis with recurrent hypopyon in 5% and posterior uveitis with retinal vein occlusions on occasion. Both herpes simplex and herpes zoster infections may cause non-granulomatous anterior uveitis. Diseases producing granulomatous anterior uveitis also tend to be causes of posterior uveitis. These include sarcoidosis, tuberculosis, syphilis, toxoplasmosis, Vogt, Koyanagi-Harada syndrome. VOGT, Vogt, Koyanagi, KOYANAGI, Koyanagi-Harada, HARADA, Vogt, Koyanagi-Harada syndrome. That is bilateral uveitis associated with alopecia, poliosis, and depigmented eyelashes, eyebrows, or hair, and vitiligo and hearing loss, and sympathetic ophthalmia. The principal agents responsible for ocular inflammation in eyes are cytomegalovirus, herpes simplex, and herpes zoster viruses, Mycobacterium, Cryptococcus, Toxoplasma, and Candida. Autoimmune retinal vasculitis and pars planitis, that is intermediate uveitis, or idiopathic conditions that produce posterior uveitis. Retinal detachment, intraocular tumors, and central nervous system lymphoma may also masquerade as uveitis. Treatment. Anterior uveitis will usually respond to topical corticosteroids. Occasionally, periocular steroid injections or even systemic steroids may be required. Dilation of the pupil is important to relieve discomfort and prevent posterior senescence. Posterior uveitis more commonly requires systemic corticosteroid therapy and occasionally systemic immunosuppression with azathioprine or cyclosporine. Pupillary dilation is not usually necessary. In all cases of the infectious causes is identified, specific antimicrobial therapy is indicated. In general, the prognosis for anterior uveitis, particularly the non-granulomatous type, is better than that of for posterior uveitis. Thank you.